This is the September 2025 MEC Minute. This month, I'm going to revisit the discussion as the MEC Minute we had 6 years ago, and we're going to talk about some EKG changes that really you should be aware of and really you should not miss because they have significant implications for your patient. So we're going to start off with 4 clinical scenarios with electrocardiograms and just take a look at them and think about what's not right with the 12 leads that I show you. And at the end of the conversation, I'll go back and revisit the 4 cases and we'll talk about the interpretation of the 12 leads and their importance to the patient. So the first up is a 21-year-old male who felt lightheaded, dizzy, and almost passed out while playing basketball. He has no chronic illness, no chronic medications. He has a family history of sudden cardiac death or sudden cardiac arrest in his brother. Take a quick look at this, and then we will move on to patient number 2. It's a 47-year-old male with exertional crushing chest pain for the past 2 hours. He has no chronic illness, no chronic medications, and he's received no treatment prior to arrival. You obtain a 12-lead electrocardiogram, which is posted here on the right side of the slide. I'll give you a moment to take a look. The next up is a 70-year-old male who has a chronic pacemaker. He is having active chest pain. You obtain a 12-lead electrocardiogram, and this is what you see. So the question on this patient is, how do you interpret a 12-lead electrocardiogram in a patient with a pacemaker that is actively pacing? And finally, we have a 40-year-old male with exertional crushing chest pain, no chronic illness, no chronic medication, and no treatment prior to arrival. Similar scenario to our second patient, but different electrocardiogram. So why are we going to talk about this topic? Well, there are electrocardiogram abnormalities that are not common but represent real threats to your patient and their safety. And we're going to talk about 4 of them. One of them is Wellen's syndrome. Another is the winter T-wave changes. We'll talk about Sgarbossa criteria for diagnosing myocardial infarction in patients who have either a pacemaker or a chronic left bundle branch block. Keep in mind, paced rhythm gives you a left bundle branch block pattern. And then we're also going to talk about Brugada syndrome, which is an abnormal electrocardiogram, which represents an immediate or short-term threat to the patient's health and well-being. So let's start with Wellen's. So Wellen's is our condition that is suggestive of subacute occlusion of the left anterior descending artery. And that occlusion over the next few days could result in an acute occlusive MI, meaning acute thrombus formation and acute STEMI. These patients will not have Q waves. They do have a recent history of angina, and typically the pattern is present when the patient is pain-free. So you may get called for the patient and they may not have pain, but they've had pain and you do a 12-lead. There are 2 types of Wellens, type A, which is biphasic T waves and leads V2 and V3. I have a picture on the next slide for that. And type B, which represents about 75% of the patients, and they have deeply inverted T waves in V2 and V3. And with time, typically type A's evolve to type B's. So I said a bunch of words. What do the pictures look like? And here we have on the left, we have a type A with biphasic T waves. So what I mean by biphasic T waves is the T wave goes up and down. So if you look at this, there's an upward component and then there's a downward component. You can see that pretty well in V2 and V3, which is typically where you will see the Wellen's changes. With time, patients can progress to a type B, which has these deeply inverted T waves. This is more than your typical flip T wave that you might see with some cardiac ischemia. These are deeply inverted and typically go a full large box in depth. So they're could be as much as 5 to 6 millimeters deep. These are not normal. These are consistent with Wellen's phenomenon and do represent an immediate risk to the patient's health and well-being. So here's another 12 lead. Here's a full 12 lead. And if we look at this one, what do we see? Well, this one looks like a Wellens type A. It's got a biphasic T wave. There's a portion that goes up and a portion that goes down. You see these changes in both V3 and V2 and V3, which is where they're typically seen. The important thing about this is it's abnormal and you should be able to see it. And if you forget that it's Wellens, at least remember that a biphasic T wave in V2 and V3 represents a risk to the patient, particularly if they have anginal symptoms. Here's a Wellens type B, and if you look at it, you've got these inverted T waves that are really quite steep. This is another abnormality that, again, if you forget the word Wellen, you please recognize that these deeply inverted T waves are concerning for cardiac ischemia and represent a high risk to the patient for acute myocardial infarction. So if you see these, this is a warning sign. I would treat the patient for cardiac disease, aspirin, nitrates if they're complaining of pain. You could easily argue that if they're pain-free but have this abnormality, apply some nitro paste. We'll move on to De Winter's. De Winter T wave changes. These changes are considered a STEMI equivalent. They represent about 2% of the patients who have acute left anterior descending artery occlusions, and they are really a part of the spectrum of acute occlusion MIs. These patients typically do not have obvious ST segment elevation. They have the ST changes by themselves. And these patients usually have active chest pain and other symptoms suggestive of a STEMI. And really, this finding has only been around for about 17, 18 years since it was first described. What does it look like? Well, here we have a 12-lead electrocardiogram, or I'm saying V3 from a 12-lead. And if you look at it, there are these tall, prominent T waves. And if you look at the upstroke to the T wave, they have some precordial ST depression and this upsloping ST segment. So this is not a normal appearing T wave. There is no ST elevation in the precordial lead, so you'll see these changes you'll see a peak T wave and the upsloping ST segment, but you will not see ST elevation in the precordial leads, but you can see ST elevation in AVR, which I will show you in a minute. These changes can either be preceded or followed by typical ST elevation that you can see in an MI. If this is your first 12 lead, then you would consider this to be a STEMI equivalent. Keep in mind that you may go from this De Winter pattern to a true ST elevation and STEMI pattern. So what does it look like on a 12 lead? Oh, I'm sorry. Here's a De Winter patient. And again, if you look at it, the patient has these tall peaked T waves. They have this ST depression on the upslope, and the upslope is kind of gradual, and that is not normal. If you look at AVR, they have a little bit of ST elevation, and typically with De Winter, AVR is the only place that you'll see ST elevation. It's not like we routinely look at AVR. I know I haven't, but it's one of those things. If the ST segment looks abnormal in V2 and V3, take a look at AVR and see what it looks like. This next tracing, this one's got a little more definitive ST elevation in AVR, but again, the patient has significant peaked T waves, and they have this sloped ST segment with some ST depression and an abnormal looking upstroke to the T wave. And you have really easily identifiable ST elevation in AVR. So this is the De Winter pattern. It is considered a STEMI equivalent. Probably the most common thing you're going to see is a patient with left bundle branch block and chest pain. So the question is, can you identify a STEMI, or is there a STEMI equivalent that you can see on a patient with a left bundle branch block? In years past, every patient with chest pain that had a left bundle branch pattern on their 12 lead was treated as a STEMI equivalent. We treated as a STEMI. We've kind of backed off from that, but we still look to see if there are other changes on the 12 lead that could indicate that the patient's having a STEMI. So there was studies put out there regarding ST elevation, or I'm sorry, regarding left bundle branch blocks, and they looked at left bundle branch blocks, and about 40% of the patients with a new left bundle branch had an acute occlusive lesion or a culprit lesion on cardiac cath. Although in these 4 studies, the range was 7 to 61%, but if you take all the patients together, it averaged about 40%. So the question then is, okay, we have a patient with left bundle branch block. There's about a 40% chance that they're going to have an acute occlusion on cardiac cath. What can we do to look at these 12 leads and see if there's something else to identify STEMI? So 20, 30 years ago, an Italian cardiologist, Dr. Sgarbossa, took a look at this. She came up with some criteria, and we now use what we call Sgarbossa criteria to identify STEMI patients on 12 lead when the patient has a left bundle branch block or a pacemaker. So these are the Sgarbossa criteria. They have been modified a little bit by another physician called Dr. Smith, but there are 3 criteria, and they are part of a scoring system. If the patient has 3 or more points based on these criteria, we consider that to be an acute myocardial infarction. These criteria are specific, meaning if the patient has these or meets criteria, so 3 points or more, then it's extremely likely that they're having a STEMI, but it's not very sensitive, meaning that we don't commonly see these patients who are having a STEMI and have left bundle branch block. So the bottom line is, if the patient meets criteria, they're having a STEMI, call it as such. And if you look at the criteria, the first one, the one that gets you the biggest points, is if you have ST elevation that's going in the same direction as a positive QRS. So if the QRS is going up or upwards, and there is ST elevation with that QRS, that's worth 5 points. The patient meets criteria for STEMI. If there's concordant depression, more than 1 millimeter, that's worth 3 points. So what that means is, if your QRS is predominantly downwards, so you have a big S wave, and the ST segment is also going downwards, that is also consistent with an acute STEMI. And then if there is excessively discordant ST elevation, meaning QRS is one direction, QRS is downwards, and the ST segment is elevated more than 5 millimeters, that is worth 2 points. So that in itself is suggestive of a STEMI, but based on criteria is not definitive. I mentioned there have been some modifications of the criteria, and the biggest modification was this final criterion, where instead of 5 millimeters of ST elevation, people are using 25% of the S wave. So if you have a downward going S wave that is 20 millimeters and you have ST elevation of 6 millimeters, that would be considered positive. But let's look at some pictures. So if you look on the left, if you're talking about a patient who normally has left bundle branch block or has a paced rhythm and is not having any cardiac issues at the time, if you look at QRS-A, you see that the QRS is upwards and the ST segment, the T wave, goes downwards. So they are discordant. They go in different directions. And if you look at graph B, you have it predominantly an S wave. It's downward going, but the T wave is going upwards. So they are, again, discordant. They go in different directions. If you look at the criteria on the right side, the first one, worth 5 points, the most left of the 3 QRSs, you have an upwards going QRS, and you have ST elevation as well. It's more than 1 millimeter. That is considered a meeting criteria. You have concurrent ST elevation that is abnormal. If you look at the one on the right, you have a predominant QRS that is downwards, and you have ST depression, even though the T wave is going upwards. So this patient also meets criteria. They get 3 points. Positive Sgarbossa is 3 or more points. This patient is having a STEMI and should be treated as such. If you look at the middle one, which is often the one that is the easiest to see, you have a large S wave, but then you also have significant ST elevation of the ST segment. And this is, I measured to be more than 5 millimeters. It's more than 25% of the QRS, or I'm sorry, the S wave size. So this is meets the criterion, but it's only worth 2 points. In itself is not definitive, but highly suspicious. So these are ways you can use to look at a patient with left bundle branch block to identify a STEMI. So let's go looking at 12 lead again. So if you look at this patient has significant ST depression that is concurrent, meaning going in the same direction as the S wave, and it is worth 3 points. This patient is having chest pain, meets criteria, should be treated as a STEMI. You can see the pacemaker spikes that precede the QRS, so you know this patient's in a paced rhythm. Here's another patient. This patient has YQRS. They have ST elevation that is concurrent with the predominant QRS. So this patient gets 5 points. They meet criteria. This patient should be treated as an acute inferior MI because these changes are in the inferior leads. If you look at lead 3, it has similar changes as well. The last item to talk about is Brugada syndrome. It was first described in 1992. The reason this is important is because these electrocardiographic changes represent a potential life-threatening arrhythmia, or at least a risk for life-threatening arrhythmia, and it is sometimes inherited, so it tends to run in the families. These patients are at high risk for cardiac arrest, even though they have normal cardiac structure. And their mortality is about 10% per year if they go undiagnosed and untreated. For some reason, the incidence is especially high in patients who come from Southeast Asia, and men or males typically are more likely to have it than females. The diagnosis of Brugada syndrome, so it is a syndrome, is based upon having an abnormal electrocardiogram and one or more clinical criteria. And the electrocardiographic changes can be transient, meaning sometimes you can have a normal tracing and other times you may not. But certain things can also make these abnormalities more apparent. And for us, probably the most common is fever. So if you're talking about a younger patient population, sometimes they develop the symptoms when they're suffering an acute illness that results in fever. But cardiac ischemia can also induce these EKG changes. Certain medications, patients who are found to be hypokalemic can develop these changes. And hypothermia also somehow provokes the abnormal electrocardiogram. So what kind of symptoms go with it? Again, the syndrome is based on having an abnormal electrocardiogram and other clinical criteria. These criteria include dizziness, fainting, gasping or labored breathing. And this is sometimes something where the patients have history of apnea, or their partner says they gasp and have trouble breathing while sleeping, and it can be associated with this EKG abnormality. The patient may have palpitations that can be intermittent and could be warning signs of pending cardiac arrest, which is more or less the ultimate symptom of Brugada associated with an abnormal 12 lead. If you look at the types, there are 3 types, and I'll show you the waveforms. And again, the important thing is you recognize these waveforms are abnormal when you look at a 12 lead. Type 1 is the only truly diagnostic type. They have coved ST segments, and they're found again in the anterior chest leads. So they have some definitive changes that I'll show you. Type 2 has a saddleback appearance to the ST segment, ST changes, typically in leads V1 and V2. And then type 3 can be type 1 or type 2, but they just don't have as much in terms of ST elevation. And again, the last 2 really are non-diagnostic, but if you see them, the patient requires further assessment, particularly by an EP cardiologist. So again, pictures are better than 1,000 words. If you look on the left-hand side, this is a type A, or type 1, I'm sorry. And you can see that there's a really funny looking ST segment, and it almost looks like a biphasic P wave or T wave, but it's not. If you look at type 2, that is what a lot of us see, particularly what we see in this one in V2. It's that saddle-like appearance of the terminal QRS and the T wave. And then type 3 on the right, it looks like type 2, just not as much ST elevation. So if you see any of these changes, particularly the one we see in type 1 on the left, this patient's at significant risk. So again, going through it, here's the ST changes for type 1 in V1. This is the saddleback appearance to the terminal QRS and the ST segment and T wave. And this is type 3 with changes, but not as much ST elevation. So how do we make a formal diagnosis of Brugada? Well, it really comes down, again, having the type 1 changes that I talked about, plus one or more findings, which would be documented episode of VF or VTAC, family history of sudden cardiac death at under age 45, abnormal electrocardiograms in family members. So if your patient has type 1 changes and another family member has maybe type 2 changes, that would be considered adequate to establish a diagnosis of Brugada. These patients, if taken to the EP lab, may have arrhythmias that can be induced in the lab by the EP cardiologist. Some of these patients can have a primary symptom of syncope, which is one of the reasons why when a patient has syncope, we should be getting 12-lead electrocardiograms, because it could be due to Brugada as well as other things such as, PVCs, VTAC, or other abnormalities. And then finally, the last criterion that can be used to identify Brugada is agonal respirations, which are usually something that a spouse or partner can tell you about. The treatment for Brugada is typically placement of an AICD because these patients are at risk for fatal arrhythmia. All right, let's go back to our clinical scenarios. Here's patient 1. 21-year-old male, felt lightheaded, dizzy, almost passed out while playing basketball. No chronic illness or medications, but his brother suffered sudden cardiac arrest. This case comes right off of our last 2 slides. So what do you think he has? Well, if you look at the electrocardiogram, he has changes in V1 and V2, which are concerning for Brugada. So again, here are those ST changes, and the patient meets criteria for Brugada syndrome because he's got type 1 changes and he is at high risk for cardiac arrest. This patient requires transport. He needs evaluation by EP cardiology, and I suspect will end up with an AICD. You can't be too young to get a 12-lead. Patient number 2, male with crushing chest pain, no chronic illness, no chronic medications, no treatment prior to arrival. Well, what do you think? Again, looking at the 12-lead, he's got these really tall peaked T waves, and he's got that sloping initial upstroke of the ST segment. So chest pain, abnormal electrocardiogram. He meets criteria for De Winter's T wave changes, and this is considered a STEMI equivalent. You treat this patient as a STEMI. Nitrates, aspirin, IV access, immediate transport, STEMI alert. All right, older gentleman, history of pacemaker, having pain. Okay, so we have a left bundle pattern in this patient. What are we going to do? We look at the leads and decide whether or not he meets Brugada, meets any criteria for Sgarbossa. And if you look at V2, he's got concordant ST depression. So the ST segment is depressed in the same direction as the S wave. This guy meets Sgarbossa criteria for a STEMI, and he gets 3 points. So this patient should be treated as an acute STEMI. Again, aspirin, nitrates, STEMI alert, transport to interventional facility. And finally, our last patient, another male with crushing chest pain. It's resolved. He has no chronic illness, no chronic medications, no treatment prior to arrival. Well, what do you think he has? Well, again, look at his ST segments. He's got this biphasic appearing T wave. So this gentleman meets criteria for Wallen's type A. It's concerning for subacute occlusion of the left anterior descending. He's high risk for acute occlusion MI, meaning he now has a clot in his LAD, and we will treat him as a STEMI, even though he is feeling improved. This is considered high risk for STEMI. Treated with aspirin. He is asymptomatic this time. You can make an argument to treat with topical nitrates, but he needs to go to an interventional facility for further assessment. I anticipate he would go for urgent catheterization that day. So the bottom line, some closing comments. I discussed some electrocardiogram abnormalities. They are not common, but do represent risk for our patients. I think the most common that you'll see will be patients with a left bundle branch block related to a pacemaker or chronic bundle branch, having chest pain, in which case you should be comfortable and familiar with the Sgarbossa criteria. If you don't remember the names of all the abnormalities, remember that the EKGs are not normal. Be able to describe them. The patient has biphasic T waves in V2 and V3, or a patient has left bundle branch block and concordant ST elevation or depression. Things that people understand. And also, I've said this too many times. You can't do too many 12 leads. Always think in patients, regardless of age, who have syncope or dizziness or some episode of altered LOC, get a 12 lead. There are some studies out there that indicate that first-time seizure patients, 25% of them have seizures due to cardiac arrhythmia. So, always get these 12-lead electrocardiograms, take a look at them, and look for these abnormalities so you can get some good idea what's going on with the patient. That's what I have. I appreciate your time. We'll talk next month.